headfirst into a really high-stakes clinical scenario, one where a single wrong move could, well, be fatal. We're going to break down this critical medical emergency and turn what looks like a complex puzzle into some super clear, life-saving steps.
Okay, so let's get right into it. Picture this. You're in the emergency department. A patient has just been rolled in, and everything is happening fast.
So here's our patient. And honestly, she's a puzzle we have to solve like right now. She is in obvious distress. And that ECG? Yeah, the clock is officially ticking. What you decide to do first, it's absolutely crucial.
All right, let's break down what we're actually seeing here. You've got the severe restlessness, the heart palpitations, the tremors. Her body is just in complete overdrive. Then you see the swollen neck. That's a big clue pointing us towards the thyroid. But that history of bronchial asthma, oh man, that is a critical piece of the puzzle. We absolutely cannot forget that.
So you take all these clues, you put them together, and a very specific and very dangerous diagnosis starts to come into sharp focus. Let's put a name to it.
Yep, all signs are pointing to a thyroid storm. And look, this isn't just your standard hyperthyroidism. No way. This is an acute, severe, totally life-threatening situation where the body is just flooded with thyroid hormones, and it's sending pretty much every system into absolute chaos.
You know, a storm like this doesn't just happen out of the blue. It's almost always triggered by some kind of major stressor to the body. We're talking about things like someone abruptly stopping their anti-thyroid meds, a bad infection, some kind of trauma, or even recent surgery. Any of these can push a person who already has hyperthyroidism right over the edge into this crisis.
Okay, so we've got our diagnosis. Now we have to act. And in any crisis where you've got multiple things going wrong, you have to follow one simple rule. Treat the thing that's going to kill the patient first.
And this really gets to the heart of the matter, literally. That uncontrolled atrial fibrillation, that is the single biggest, most immediate threat right now. It puts her at huge risk of going into cardiac failure, so our number one job is to get that heart rate under control, and we have to do it now.
Now, here's something that might surprise you. When faced with this exact scenario, only about 40% of people get the answer right. That's kind of scary, right? It really highlights a super common and potentially fatal mistake in how this is managed. So let's dig into why so many people get this wrong.
All right, let's look at our options. We're going to walk through the clinical reasoning here so we can logically figure out the one right drug for this specific patient. So, your go-to standard treatment for rate control is usually a beta blocker, right? Something like Propranolol or Esmolol. But remember that one critical detail from her history? The asthma. For this patient, that means beta blockers are completely contraindicated. They are an absolute no-go.
And here's why that's so important. Giving a beta blocker to this patient could literally trigger a massive, life-threatening asthma attack. You'd be trying to fix one problem, the heart rate, but you'd be creating another, equally deadly one with her breathing. This is the pitfall. This is the exact reason why only 40% get it right.
So let's walk through the mental checklist. Step 1, identify the problem. We've got rapid atrial fibrillation. Step 2, what's the standard treatment? Beta blockers come to mind first. Step 3, and this is the big one, are there any contraindications? Yes, the patient has asthma. So, step 4, we have to pivot to the safe alternative. And in this case, that alternative is a calcium channel blocker, specifically Diltiazem.
Okay, so we've given the Diltiazem, her heart rate is starting to come down. Phew, crisis averted, right? Well, not exactly. Our job is far from over. We've only put out the biggest fire. We still have to deal with the underlying storm that's causing all this chaos.
Yeah, managing a thyroid storm is like a full-on, multi-pronged attack. It's not just one thing. After we've got the heart rate under control, we start with supportive care, things like IV fluids and ice packs. Then we bring in the heavy hitters. We use propylthyrosol, or PTU, and its job is to block the thyroid from making any new hormones. After that, we use iodine to stop the hormones that are already made from being released. And on top of all that, we give corticosteroids to help reduce the conversion of thyroid hormone into its most active, most potent form.
Okay, I really need to emphasize this next part because the timing here is absolutely non-negotiable. You have to give the PTU about an hour before you give the iodine. Why? Think about it. If you give iodine first, all you're doing is handing the thyroid more fuel for the fire. You're giving it the raw material it needs to make even more hormone, which would just make the storm 100 times worse. So yeah, the sequence is everything.
Whew, okay, that was a ton of information. I know. So let's take a second and boil this entire case down to the most important, must-know takeaways. All right, here are your clinical pearls. Number 1, in a thyroid storm with AFib, you control the heart rate first, period. Number 2, always, and I mean always, check for contraindications like asthma before you even think about giving a beta blocker. Number 3, know your safe alternative, which in this case is Diltiazem. And finally, remember that treating the full storm is a multi-drug regimen that has a very specific critical sequence. You got to get that order right.
And I'm going to leave you with one final thing to think about. We talked about that. You have to give PTU before iodine. But I want you to really mull over the why. Because understanding the deep pharmacology behind a rule like that, well, that's what transforms just knowing the guidelines into having a true life-saving